morning, or rather good afternoon even. My name is Geraldine Strathdee. I work at the Maudsley Slam as a non-executive director. These challenging conversations we have done once a month for the last 6 months. And in them, we discuss issues that are major challenges, particularly to the world of mental health, but also to wider society. We have no holds barred conversations here because we want to try to get to the truth of what people think, what they think we should do about it, and to really just celebrate the fact that we can be open and honest about some of these big challenges. So what we'd really like to do today is to focus on, it being the Christmas season, the very, very contentious topic of alcohol. We know that alcohol causes major challenges to people, to their families, to health system organizations, to wider society. We know that we have a policy in this country, or let me think, do we have a policy in this country that could actually make effective change? We have very many people involved in different echelons of society thinking about this. But in the 44 years that I have been a practicing doctor working in the community, in mental health services, I am not sure we really cracked this. So I'm joined today by people who have all of them had a major influence on my life. I like to regard them as colleagues I love to spend time with, hence the Christmas thing, but also amazingly knowledgeable people who've walked the streets, who've sat in high chairs, and who can tell us, I think, the best debate we can possibly have about alcohol. So let me start off by getting them to introduce themselves and just say for 4 to 5 minutes what they think about the whole issue of alcohol. Whose job is it? What can we do about it? Can I start with my very, very good friend and my own social media trainer, ex-journalist, Ed Davie. Ed, tell us about yourself and all your many roles that have impacted on your views about alcohol.
Thank you, Geraldine, and trust you to have a Christmas party that consists of us all talking about alcohol and mental health. But you know, that's how I like to spend my time as well. So thanks very much for having me. So yeah, my name's Ed Davie, and where do I start? Well, I'm a recovering journalist, as Geraldine said, but I'm also a recovering alcoholic. I worked out this is my 4,183rd day sober. So that's an achievement of sorts. So I've made it through the day so far sober, so that's good. And it was this time sort of 11 or 12 years ago that I lost my job as a journalist, a political correspondent. I got made redundant, and it was just before Christmas. And I knew my drinking had got really bad. I mean, it predated my redundancy by many years, but like a lot of these things, it kind of sort of brought it to a head, and I knew that I had to do something about it. But funnily enough, I thought, oh well, Christmas is coming. That was my excuse for not grasping the nettle at that point, because obviously in our culture there's a lot of drinking around Christmas, and the addict in me thought, excellent, I can put it off dealing with this for another few months. But unfortunately that obviously made my life even more difficult, and I did manage to give up for a bit after the Christmas, but then I relapsed really badly. And my wife, as you just saw there, she left the house because I was being, my behaviour was so awful with our then young daughter, and that sort of made me even worse. And I was drinking spirits all day, and in the end, really badly affected my physical health as well. And I ended up in King's College Hospital in the general medicine ward. And, I'd annoyed everybody, even my mother. I'm the youngest of 4, and, I'm the baby of the family. And I remember her visiting me and throwing some pajamas at me and a toothbrush in the hospital. But even she was obviously really, distressed and upset with me. And I thought, oh, God, if I've even upset my own mother, and then things must be really, really bad. So that was kind of what they call rock bottom for me. And I just thought, like I say, I had a period of sobriety where I'd been really happy for a few months. And I thought, was really happy. I was doing really well. I was enjoying fatherhood. Things were going all right. I'd managed to get a new job. And look at me now, you know, in King's College Hospital, I've pissed everyone off. Sorry, excuse my language, but we're going to have a no holds barred conversation. My then girlfriend's left me with my daughter, with our daughter. I've annoyed my mum. No one else cares about me anymore because I've just annoyed everybody. And I knew then, you know, that things could either get much worse, or I had to do something about it. And luckily, I had access to a liaison psychiatrist in King's, and then I got discharged, and I was an outpatient, funnily enough, of Mike's. We're going to hear from Mike Kelleher, who runs the Maudsley and Consortium Drug and Alcohol Service in Brixton for Lambeth, and very brilliant it is too. So I am a graduate of
Ed, you've just muted, I think, at the end, so we just missed the last sentence.
Oh, sorry. So I was fortunate that I had really good services in Mike's. We're going to call it Mike's Clinic now. We should put that above the door. I had really good services, including cognitive behaviour therapy, group therapy, couple therapy. I don't think they have it now because of cuts. But they even had a creche for our daughter, so that me and my wife could have time to work out things whilst our daughter was in the creche, in the actual clinic, which I thought was amazing service. So thanks to that, and thanks to my family and friends and my own willpower, I've managed to recover and do lots of interesting a local government councillor with responsibility for children in Lambeth at the moment. But it did make me think, you know, I am a white middle-class heterosexual with an education and a supportive family, and my recovery was definitely aided by all of that unearned privilege. And I saw other people without that privilege, Black people, LGBT people, working class people, who suffered worse outcomes through no fault of their own, just because I enjoyed all of this other privilege. So it's kind of if it doesn't sound too highfalutin and grand, my mission is to try to extend the opportunities that I've managed to enjoy to other people, whether that's in the provision and access of services like Mike's, or almost more importantly, on the wider determinants. So obviously that's you know, we know poverty is a big driver of ill health, including problems with substances and mental illness. We know that racism has a major impact, and childhood trauma of all kinds. So I always remember Geraldine saying to me, you know, if we could eliminate child poverty, abuse and neglect and bullying, I would hardly have any patients left. And I think that's true. And I think as important as services are, and we're all in the sort of service business, including me as a recipient of great services, we also should all be in the business of preventing people having to use services. If we all, as Geraldine says, you know, lived with the resources we need to fulfill our potential, then we could make a big difference. And that I always like the World Health Organization model, which talks about three things that determine health and illness: personal, individual factors like genetics and psychology, environmental factors, and in this case it's things like the frequency of off licenses, which I know Mike's done some research on, but the availability of alcohol and the kind of environment we have, housing, access to green space, access to good community facilities and jobs and all the rest of it. And the third one in the WHO model is social determinants. So poverty, inequality, racism, what we're going to do to tackle all of those things. So services are important. They saved my life, and I'm not exaggerating. But so are the wider determinants, and especially in alcohol, when you think about the mechanisms that we could have around pricing and tax and licensing policy and all of that, there's a huge potential to do so much better than we do in this country. So I'll leave it there. I hope that was challenging enough. I swore a little bit there, Geraldine, so that's my bit of edginess for you.
Do you know what, Mike? I didn't even notice the swearing. That's just, you know, how it's Christmas. But no, thank you very, very much for sharing that with us and just making it so real. And we will come back to you because I think you've been very modest about the things that you have done in your role as a local councillor, and that you've certainly done in working with the National Mental Health Foundation, population health charity. Can I come on then to Mike Kelleher? Mike, I know because Mike was one of my absolutely, totally top most gifted trainees. I had the huge privilege to work with Mike, and I just endlessly watched his journey and admired his utter passion for outreach to the most disadvantaged. But Mike also has another role, which is he has been the lead in Public Health England for dual diagnosis. So Mike, give us your views. Alcohol, where are we with it now? Are we making progress? What are its impacts?
Thank you, Geraldine, for your kind words, and also yours, Ed. It's always appreciated. I think before I move on to the stuff, just a note. I mean, Ed's noted it. The service Ed received 10 years ago or more now, 15, isn't available now due to loss of services. So you're right, Geraldine. I have two roles. I'm clinical lead for addictions for Lambeth, the Maudsley, at the consortium, which is really a conglomerate of the voluntary sector and the statutory sector, trying to bring the best of both together. But I'm also a national clinical advisor to Public Health England for alcohol and drugs. And I think, Ed set it out quite nicely, really, at the human level, but also the population level of what we need to do and perhaps what's gone wrong. And I think broadly in all substances, we think broadly about supply reduction and demand reduction. And my personal view is that we've got this badly wrong at both ends when it comes to alcohol in this country. And Ed's talked about the work he's been leading on and trying to push, but the local authorities' hands are tied, I think, largely in this, what they can do, but in the supply reduction. And I think the last time I visited this topic, there were more places in Lambeth where you could buy alcohol than you could buy fresh food, which is a remarkable, it's a truly remarkable statistic. And there's a phenomenal level of both off sales and on sales. You can get alcohol delivered 24 hours a day, and it is incredibly cheap. So I think the two areas where we haven't addressed this enough is with the supply reduction. And as I'm a man who likes to drink, I enjoy a drink, although as I get older, I drink much, much less because I find it has a woeful effect both on my mood and my energy. But I think reducing the availability of it through licensing, restricting licensing hours, restricting its available, not allowing it to be delivered, making people work a bit harder. And when the politicians say, oh, we want to preserve the economy, well, actually, a pint of beer is much, much, much more expensive in a pub than it is in an off-license, So if you even approach the level of cost in a pub for off-license sales, you might generate more people going out to your nighttime economies. So reducing the availability, changing the area through licensing, but also I think minimum unit pricing, and I think these are things we need as a country, we need to grasp. And the evidence for both is clear. Tony Blair had an idea that we could have a cafe culture. The United Kingdom, nor the homeland of Geraldine, myself and Derek, we don't have a cafe culture either in Ireland. We have a hard drink. I mean, the attitude to alcohol I had growing up in Ireland was truly appalling. It was what you did when you finished a match is what you did. We didn't have that culture. So I think there were restrictions there. But at the other end of the scale, I think alcohol services have suffered, and they've suffered because there's many reasons, and addiction care as a whole is stigmatized, I think, and people struggle to do it. But the particular thing that drove a nail into us was really the Health and Social Care Act, which took us out of the NHS and put us into the local authority. But of course, the local authorities have had year-on-year cuts to funding, and they have really suffered. And if you're someone like Ed, and you're looking about what you fund, and I have to say Lambeth have been fantastic in supporting our services, but when I look around the country at other local authorities, and they're making tough decisions about what do you fund. And we've gone from a tiny percentage of a local NHS budget to perhaps the largest single part of a local authority's public health budget. And that budget has been cut, centrally. And so they've struggled to fund services. And so services are forced to retreat. And last month, we had more alcohol referrals in a single month than I've ever had in the Lambeth services. Wow. And we have fewer staff to deal with it. All the psychology that was there before, because and it's something worth talking about, because a lot of our patients are actually excluded from mental health services. They're excluded from psychology services. The old psychology we had, that's largely had to be cut. I think before just to hand on, just thinking about a few statistics just to think about in our heads. Alcohol is the leading cause of deaths in adults under the age of 50, which is a remarkable thing to say. And even if you look at suicide, so with the wonderful Nikki Kalk, who's my colleague, and she's the liaison alcohol consultant at King's, we looked at the study in London, which I have to be honest, psychiatry didn't really want to publish, but we looked at all the suicides. It's a terrible term, but it's the best one we've got, violent suicides in London. A third of them were intoxicated at their point of death. That's what the estimation of the pathology, and this is all suicides. We know from the National Confidential Inquiry into Homicide and Suicide that over half of psychiatric patients who kill themselves are dependent. That's not just using, they're dependent on alcohol or drugs. And again, Dr. Kalk, Nikki Kalk, has done a lovely study in the 136 suites across the road in the Maudsley, and of presentations. And over half the people who present to the 136 suite, that is, they're picked up by the police, are intoxicated. And one of the awful things you see, and is that people look at the alcohol and they say, well, it's an alcohol problem. But the important thing, if someone is suicidal, is they're suicidal. That's the number one problem. It's not alcohol. Alcohol is secondary. You might need to deal with the alcohol, but the important point is that they are intoxicated. And if they sober up the next day and they say, I really regret what I did, I shouldn't have done it, I'm apologies, that isn't a wasted bed for a night. That isn't a waste. That's the psychiatric equivalent of cardioverting someone's heart. You may have saved someone's life by stopping them doing something impulsive, which is in all our remits in those moments. So the interface with psychiatry is really, really important. And just one last point to make actually on that. Dame Angiolini, she brought out a review into deaths in custody, very important. And a lot was made of psychiatric deaths in custody. But actually, what less was made of, but she made quite a lot of, but didn't get picked up, is that half the people who died in police custody, alcohol or drugs played a role in their death, a direct role. And I think it was something like 85% alcohol or drugs played some role. So in all our most problematic interfaces, this is a really important problem. And one that, as Geraldine has alluded to at the start, we've really struggled to come to terms to. And there isn't an easy answer. It's not there's no magic solution to this. It is a collaborative solution. So I look forward to other people's contribution, maybe entering a further debate on this. Thank you.
Great. Thank you very, very much, Mike. Very, very much. Very, very thoughtful about the challenges of this, and kind of really sad to hear that the service that Ed is so articulately saying was needed, holistic care, family involved, psychological therapies, is so disappeared, is just so much less in prominence. That's kind of really concerning. So before I come on to Derek, Becki, could I just welcome you to the panel, get you to unmute yourself, if that's okay.
Yeah.
Lovely.
Can you hear me?
Can hear you perfectly. Now, we've talked a lot in this so far about the impact of alcohol and its impacts on society, also on mental health system, on suicide, tragic event of suicide. Mm-hmm. But you work in, as I understand it, an acute, hard, sharp end of an acute hospital. Could you tell us a bit about yourself and your role and your attitudes and experiences with alcohol?
Yes, so I've been working with actually Dr. Kolk's team, and Mike mentioned doing some studies and research with Dr. Kolk. So I've started working with the alcohol care team at King's College Hospital in April. And prior to that, I worked at the Beresford Project, which is a SLAM service, a complex needs, community-based addiction service that unfortunately lost the contract under the tendering process. After 31 years of having a public health service, really has gone out to non-statutory services. So I suppose what we've been seeing here, if I work around what's happening at the moment in what we're seeing in King's, is a lot of people sort of representing people maybe that have been abstinent or a change in people's drinking habits, exacerbated by the recent pandemic. So we're seeing quite a lot of that at the moment. A lot of support services are being cut, peer support, more pressures in society, on top of like even people engaged with community services or addiction services having their contact moved to telephone contact. I mean, I've had IT issues this morning, so I can imagine if you've got alcohol on board, and you're trying to navigate these things, how difficult that must be, as well. I suppose, and I could relate a lot of the things that Ed was mentioning earlier, and Mike, both the impact of how alcohol affects not just the individual, how the ripple effect goes on and affects families, affects communities, affects the wider area. And I really think that we do need to have a joined up approach. I think that my experience really is working from a complex needs perspective, and I would always find that the more services or the more support available, the better. It's such a multifaceted area and affects so many aspects of health and social care and of people's lives that we need to consider the bigger picture as well. Was there anything sort of particular that would be helpful for me to talk about at the moment from an acute perspective? Or
I think it'd be really helpful, dear. Because you're what we describe from the Moseley as across the road, aren't you? You are in the A&E department, you're in the acute hospital. I don't know how much contact you have with the liver units and the kind of major trauma and the intensive care units, because we know that people present with alcohol as a component part of the problem to many of those services as well. And I know that domestic violence sometimes presents as an alcohol problem, and to just tell us a bit about what are the challenges people come into you with, and what in an acute trust can you do?
I suppose, I was quite surprised. So our referral pathway, if you compare the numbers from this time last year, so during the pandemic, while the rest of the hospital was generally quite quiet, it definitely slowed down with a lot of people reducing their access to services. We found that our numbers, they did drop, but they were constant. Exactly what you were mentioning, we were finding a lot of people still coming in, having things like falls, traumatic injuries, and coming in needing withdrawals. So I was quite surprised that was still happening. I think we were kind of all prepared that we might have seen people needing to come in. We were unsure whether shops would still close, whether people would be coming in needing detoxes. We were kind of, considering that, but we didn't see much of that. It seemed like, as Mike was saying, you could still access alcohol through, even in the strictest lockdown the first time around. It seemed like accessing alcohol wasn't problematic. We've seen people coming in from all areas. We see a lot of major trauma, people coming in where there's alcohol involved. But yet every single area, I've been surprised, really, we see people in every single area that comes in cardiology. We've been seeing a lot of people coming in, and actually in the last week or so, we've had 3 patients in one bay that have all come in with confusion. And it seems, unfortunately, that they've all developed some kind of Korsakoff, so like long-term neurological injury based on their alcohol consumption. And, people that maybe are not engaged with services, or maybe have never been engaged with services. So, the huge portion of people that we're not even having contact with, that we're not, services aren't even reaching at the moment. And it's quite a surprise, really. I suppose from our perspective, what can we do? I mean, we have had a few people presenting asking for detoxes. And obviously, because I've only worked here since April, I don't know if that is a regular thing, but people coming in saying, I can't access it during I was supposed to be going to a rehab and that's now not on the cards, or I can't have any contact with my key worker. Is that something, I need to have a detox? And obviously that's not, acute hospital isn't the appropriate environment to do an unplanned detox, less than, and someone might want to correct me if my statistics are out of date, but as I've heard it's less than 10% of unplanned detoxes in hospital work. Because the preparation work's not done. I've had people that I've worked with and service users explain to me that in a way, the detoxing bit is the easy bit. It's then making those changes into your life stick. And obviously that's where the limit of what we can do in acute hospital ends, and where I think, the peer support and the other sort of social aspects plays such an important part in the process as well.
That's really, really, really helpful in giving us just another part of society, another part of the system that is seriously impacted. So can I finally come to my great friends? Well, that one person that I am deeply envious of, Derek Tracey. If I could write like Derek, I mean, you know, I can never aspire to sing, but if I could possibly write, I think Derek, you and Ed should have conversations. You know, editor of journals, clinical director of Bexley Services outside London, crisis home treatment team, right at the sharp line consultant. Derek, I know that you have major roles at different echelons of our society and government thinking about issues of addiction. What's your perspective on alcohol?
Thanks, Geraldine. I suppose two things to say to people about my role. So one is, as you mentioned, I'm a clinical director of an integrating service of health and social care. And I'll come on to that. I think there's a real opportunity at the moment with integrating care to move things forward. I think we've done things badly to date, and it's been laid out by others. My other role, which I guess is of interest to this, I'm a member of what's called the Advisory Council on the Misuse of Drugs. So we advise the Home Office and the Home Secretary on drug harms. Interestingly, which again I might come back to, there's one drug we don't talk about, which is alcohol, which is something quite interesting of itself. But to go back to services, so my real interest is how we deliver things. So I think we've done it really badly. So it was mentioned by Ed and Mike about how the local authorities, the role has been handed to local authorities. And we have this classic issue, health and social care have been divided into professional silos. Services have grown up based around professionals and what they do. No individual who uses services would ever design the services we have now. No one who uses services would say, well, if I need social care, put them over on that end of the bird. If I have mental health problems, put them over there. If I have physical health, because of course I'll never have more than one problem at a time. And if you could you give them different IT systems that don't talk to each other and different email addresses? But that's what's evolved over time. So we have this partition of services. But people aren't that simple. Life's not that simple. I can't think of many people who've had difficulties with addiction that it's not impacted their social well-being or their mental health, and vice versa. So I think we have this real problem in how we commission and deliver services. As Mike has mentioned, it's been cut to the bone. So services have really been stripped back. But I think a follow-on from that has been that within more general mental health services, I think we ever more see it as a specialist skill set. So if someone comes in and says, I have a problem with alcohol or with cannabis or cocaine, we think, okay, go see the specialist in substance use. And people think it's not their problem. But it is our problem. If you see people, if you work with people in society, drugs and alcohol are there. And in the same way, if someone comes into me and says there's a problem about domestic abuse or about their employment or their education, I can't say, well, I'm not a teacher or I'm not a social worker. It's part of people's lives. But I think we've become de-skilled in how we deliver it. I think there's an opportunity. So again, where I work, we have integrated adult mental health, adult social care, and we've integrated physical health. Now, we haven't cracked it. I'm not saying it's done perfectly here. And actually, we have several things that we've not yet integrated, one of which is alcohol services. And we haven't integrated CAM services. So lots of people operate in things called families. So we, at the moment, don't have that integrated within our care, and learning disabilities and so forth. But I think if I look about, as a manager in the NHS, I'm eternally optimistic, I think, by temperament, and I have to be as a healthcare manager. I think there are ways we can do it. What we can't do is the current model to me. So if I have a controversial statement, it's broken and it's unfixable in its current way. We would all like more resource. If more resource was given, I don't know what Mike's thoughts would be on this about specialist services. I don't think we would just pour it into having more of the same as we have it now. I think we need to do things differently. I think the biggest thing to me is the pull together of social care and healthcare. A challenge for us going forward in integrated care systems, these are nationally mandated. Wherever you're living, if you're in the UK, you must be under an integrated care system, whether you know it or not. There's no granularity in how you have to do it. So in one sense, there's lots of opportunity. So we're told, do what is relevant locally. So maybe Bexley is different to Lambeth, it's different to Glasgow, it's different to Cornwall. But we also lack good roadmaps on how to do this. What is the right thing to do? But I think the principle of bringing services closer together, having working in a much closer fashion. So within Bexley, what we're doing is adult social care and mental health are going back into single geographical teams. Now, this presents a different challenge for us, is we still need specialist teams. And that's not just true for substance use. We think about psychosis or depression. You always want some people who are very specialist in what they deliver, but we need some generic skills. And I think we need to upskill staff more generally within healthcare. And then the other opportunity of integrated care systems is I think we're beginning to have fuzzier boundaries outside. I used a phrase and I got pushed back on it before where I said it was a social enterprise, Bexley Care where I work. And apparently for some people, social enterprise brings up models of corporate takeovers. What I meant is we're part of people's communities, we're part of people's lives. We can't have high fences and firm gates. We need to have fuzzier boundaries with third sector organisations, with community groups. And really health and social care need to get out of their silos, pull down their walls and really be part of people's lives. It's not about us fixing people and their communities. It's about us being part of people's lives, part of social messaging.
You're on mute.
You're on mute.
Thanks so much, Derek. That was a really, really thought-provoking contribution. Thank you. And we'll come back to you about Bexley because we've got Lambeth Alliance model. I mean, it sounds like moving closer to integration is one way forward. So we've got two really interesting comments in the chat. So one is from Karen Minikin, who says, to all panelists, I'm a psychotherapist in private practice. And one of my social concerns is the fragmentation and provision between the NHS, private practice and charities when it comes to mental health. I wish we could provide so much more via the NHS. But in the absence of that, charities and private practice are picking up folk who get missed. How can we link up better? Should we have a massive restructuring of mental health provision in this country? Is there a political will for this? So that's one question. And the other kind of really interesting question comes from Belinda, who's joined us as an occupational health physician, who basically says she spends her life trying to talk and communicate with employers and GPs and psychiatrists. And so we do know from all the stats, and correct me if I'm wrong, Mike in particular, but we do know that probably one of the greatest challenges that employers face in sickness absence is due to alcohol. And yet, how much training are we providing for people that provide those services? Because it's so pervasive across society. So who'd like to pick up Karen's point? Do we need a massive restructuring of mental health provision in this country? Is there a political will?
Ed, please go. You go first.
Well, I mean, so we've kind of touched on the last massive restructure, right? The 2013 Health and Social Care Act that Mike referred to that moved public health from the NHS to local government. Now, obviously, Mike was very careful and diplomatic, and I appreciate that, Mike, to say that the cuts that his services endured are not Lambeth Council's fault, that we were passporting on effectively some, not all, of the cuts we've experienced. So public health, since it moved from the NHS to local government, has lost £1 in every £4 that it used to get, despite rising demand. And that's not by way of an excuse. However, that being said, I personally think that public health moving to local authorities has been a success in many ways, because it's connected up in the way that Derek says, in the way that people live. So people don't live in little silos and just have symptoms of problematic relationships with alcohol or schizophrenia or whatever the diagnosis is. As you've said to me before, Geraldine, about particular patients, you've been told to treat someone with a diagnosis of schizophrenia, but the guy's living in his car, addicted to crack cocaine, estranged from all of his loved ones. Now, unless you address the social needs of that guy, you're not going to have a chance to support him to have a better medical type of outcome. And actually, I think local government, as imperfect as it is, and it is very imperfect, has some of those sort of different connections and some of the wider determinant stuff about housing, about community, about leisure, about parks, green space, transport, employment, all the rest of it, education, that the NHS traditionally hasn't had as much, although it's been very good often in treating people like myself when I'm in crisis. So I think when we think about restructures and structures and all of that, it's like Derek says, people live in neighbourhoods, they don't care particularly which label of which thing, whether everyone loves the NHS, it's like a religion in this country, and fair enough, right? So it's an amazing brand and an amazing ethical framework to work within, and that I'm sure we all support. But at the same time, we do need a variety of kind of different offers and different things, and they do different things. But within it, we've got to think about what it means for the individuals and the communities that we serve. And it's about being close to them, responsive to them, working with them, and not delivering things to them in a kind of paternal way. And local government, I think, has a really strong role to play in that because of its democratic kind of mandate. And one of the imperfections, and we're having challenging conversations about the NHS, is it is very institutional, often based around a hospital, based around a building, and it's really difficult to drag things out of that, however people might talk big about that. And also often, when I first got the job as cabinet member for health and social care, I went to the King's Health Partnership conference, and they all talked a big game about social determinants. I looked up, not one single one of those institutions was living wage accredited, right? They were all paying poverty wages. I'm pleased to say that I and others helped persuade them to address that, and that's fantastic. But they were talking a big game about wider determinants and poverty and health and all that, but they were still paying their cleaners under the poverty line. So we all have our imperfections. We all need to help each other with the things that we do well, but it's got to be at a community level as far as possible. But there are some things that are more efficient, like specialist services that Derek talked about. So it is complicated, and we need to continue to evolve it, but also things need to be correctly resourced. So the problems that Mike's experienced are not, I don't think, a structural thing to do with being a local government. It's because there's not enough funding for the very important work that he does.
Great. So, Mike, what about your comments as someone who does actually embrace not being based in a hospital and getting out there?
I mean, I love learning from you, Geraldine, all those years ago down in Annally and Penge, getting away from the institution wherever Oxley's had their hospital in those days, being out to where the people are. And I think it's the right place to be. And I hear exactly what Ed and Derek are saying. But I think we're a slight warning, of something else that happens. And we fully embrace integration. We fully integrate the local authority. And indeed, long before the Health and Social Care Act, every local area in the country, in England, certainly had a drug and alcohol action team where all the partners were brought to the table, the police, and they turned up. I don't remember Commander Andy Tarrant, Ed, in Lambeth was one of the police commanders, and a very high level. But, and there is a but to this, there's a couple of things, and this isn't unique to being part of the local authority. Firstly, we are commissioned and tendered in a way that no other part of the NHS or healthcare services are. And this isn't really He worked for the Rand Corporation and introduced things like the body count in Vietnam. And when he was finished doing that, he moved over to Europe and he became a health consultant. And he created a seminal paper called, for Ken Clarke, when he was Secretary of State for Health, called Creating the Patient-Driven or Patient-Centred NHS, at least. And this came up with the idea of the purchaser-provider split. Now we've lived through the purchaser-provider split, and all you guys like Derek and Geraldine, whatever, you've moved beyond the purchaser-provider split. You've got your ICSs. But as Becki experienced in Greenwich, the purchaser-provider split remains, and we are forced to competitively tender regularly for contracts. And unfortunately, in an environment where costs are constrained, and I am thankful again, Ed, I'm not saying this to promote you and be nice, I'm thankful for running a service in Lambeth where we're very well working with the local authority and been supported for a long time with them. But generally speaking, the contract will come down to price. The economic term, I believe, is a monopsony, not a monopoly, a monopsony. So you can all look that up later. But we'll come down to price. And I think addiction services have suffered. Alcohol services have suffered because of that. So I'm all for integration. I'm all for working with my colleagues and my partners in social care, which I think has been fantastic, and the integration with them. But I think that there are problems with how addiction services are tendered. To one of Derek's point, I think one of the problems with moving back into mental health, there was a reason, I think we didn't do well under mental health, and we didn't do well under public health either. I think the home for addiction services, alcohol services, hadn't really been discovered yet. And one of the problems you had when we worked fully under mental health, and one of the reasons, and things were introduced for a positive reason, one of the reasons that tendering was put in first day is that you had alcohol and drug services who were doing a fantastic job treating tiny numbers of patients, you know. And obviously in a borough like Lambeth, you've got like 5,000 plus people dependent on alcohol, and you need to work at scale and volume to treat them. And so that's why tendering was introduced, to remove that. And that's one of the things that began it. But obviously, I think we've now suffered perhaps under a paradigm which sees things largely through prevention. But going back to the statistics we talked about earlier, you know, alcohol is the leading cause of death in adults under the age of 50, a major driver of domestic abuse. I think a third of parental serious case reviews where children are seriously harmed involves parental alcohol misuse. You know, it is there, and this requires individual intervention, and often quite intense individual intervention. Thank you.
Derek, do come in.
I think that's a really important point of Mike's, and it's not just addiction services. So one of the challenges, and very real challenges for integrated services, is a loss of specialism and specialist input. So the anxieties within integrated care service or within psychosis. So there's a reason we have early intervention and rehab psychosis services, is because people who use them traditionally don't do well under larger generic community mental health teams. And this is a big anxiety. I don't have an answer for it, except to say that if we build the service either around the professional or around the person who uses it, it has to be around the person who uses it, and then professionals have to find a way to make it work. We currently build it around the professional. I do think, though, that you're right, that there's a layered element to this, and there is, to me, Mike and Becki are the sharp edge of the spear with this. So they're taking frontline addiction services, but there are also multiple layers beyond it. So within my crisis team, so many people, it's a problem. But I think, to go back to the question, it cannot be more of the same. The answer to the rise in diabetes in the UK is not more endocrinologists. And the rise in myocardial infarcts is not more cardiologists. That's treating it the wrong way around. And that we have to start looking at these are social issues and societal issues, and we have to be part of people's neighbourhoods. We need to have cardiologists, and we need to have endocrinologists, and we certainly need addiction specialists. But I think typical Western economies invest about 5% of their money into preventative work, and yet that's always where the biggest gains are. But it's much harder to invest money because something might not happen some years from now. It's a very hard political thing to do. But that is always where the gains are. It's so well evidenced time and time again. But to go back to the earlier points, we have a limited budget. Who do you pull that money from to invest in preventive service? They're really hard choices, but we need to be working in much better community-based ways in neighbourhoods.
Yeah. Can I sorry, Geraldine, just on that, because we were almost getting to the supply side rather than the treatment side, and the treatment side is really, really important. And Mike's points are really well made and very important ones. But I mean, in Scotland, so the benefits Derek just said take a while to feed through, but actually in Scotland, where they introduced minimum unit pricing, very quickly we've seen incredible benefit where alcohol intake has reduced by about 25%, and it's reduced most dramatically for the most problematic drinkers. So it has an effect, the sort of social drinkers that Mike was describing himself as. Particularly, which is a good thing. We don't want to penalise people just for enjoying a pint of Guinness, I'm guessing, but I'm stereotyping there, Mike, or whatever it is. But it does stop the kind of white linings and the super strong lagers and the spirits and stuff like that. And it promotes pub drinking, which is a place of community and is an important place in our culture, and that has lots of positive health and other cultural social benefits. So I think, so Newcastle have introduced a localized minimum unit pricing system. It's hamstrung a lot by national government failure on this, but Scotland have shown us the way. We need that in England. We're looking at introducing it in Lambeth, but again, it's limited in its scope. But we have managed, through licensing. You mentioned all of those off licenses in Lambeth. We used to have 50 24-hour off license in Lambeth, and now we're down to about 12, and I'm determined to get rid of them as well. So it shows you can make progress with political leadership, and licensing is one of those things that's really important. It was the one thing that used to stop me drinking, actually. I couldn't get a drink on a Sunday, and it was a little fire break that actually reduced harm, in a kind of harm reduction model. So I think that's really important, along with pricing, along with advertising. Cigarettes have shown us the way, plain packaging, advertising bans, all of that stuff. We've got to have the we need to be more organised as a group of
Yeah.
people concerned about this issue, because the alcohol industry is a very powerful lobbyist.
Okay, so let me ask another question. Becki, perhaps I can ask you. So often when you say to me, Ed, the NHS is like a religion, and I go, like most religions, there's a lot of people believe in it, a lot of people will fight for it, and a lot of people will actually, lobby and persuade others. So why is it that local government, which must be the part of the system that suffers the most from the failure to have political will about alcohol, from the kind of the not being able often to tackle the root causes, but also from the lack of provision? Is it okay to say poor local governments lost money? Because the NHS has been through periods when we've lost money, and then we've all girded our loins, joined together, and done something. So Becki, as a young feisty person, what do you think about the NHS? And do you think we're a very good lobby group? And have we got things we could help local government with?
I suppose from my experience, what I would have seen is, like Mike was mentioning about like the tendering process. When the NHS, if we're having to be competitive, this is like Mike was mentioning as well, addictions is one of the only areas where we have to tender for services. And, the people that are very often doing our contracts, we don't have a whole new department necessarily that are doing that. It's something that we're taking on, addictions professionals are taking on top of our everyday roles, when we're going competing against a lot of non-statutory organisations that will have whole business departments that are focusing on tendering and competition. It's something I think we do need to pick up speed on or get better at in the NHS if we want to sort of keep our fingers in the addictions pies, for want of a better term. I think it's in terms of local authority, it's difficult. The borough I came from, our commissioners changed a lot, and sometimes I think we were talking to people maybe where how much experience or understanding of addiction have they come into the area when they're deciding budgets from. I know Ed's got experience of the area, but does everybody that comes into commissioning it? It's very difficult. And like Mike was mentioning, I think sometimes it has to come to money, that everyone is so stretched, and actually unfortunately when it comes to it, if it's competition about who deserves or not, is considered socially deserving of finances, then very often people with addiction issues are considered at the bottom of the pile. There is this sort of stigma of people with of addiction, and I think that has a big impact on service provision from what I've seen, I would say, unfortunately.
Sorry, no, go for it. Apologies.
No, I was just also going to mention, briefly mentioning back to the question before about structuring of mental health services. The other thing I would have seen in the community is some of the poorest people with mental health conditions I've ever seen. I'm a general nurse by background, and apart from seeing people coming acutely mentally unwell into the A&E department, in the community, we work in addiction services, we work with some people with some severe mental health problems, severe trauma, severe mental health problems affecting every aspect of their lives, but they weren't able to access mental health services because they were using alcohol. And I was so shocked at that. And I am concerned. We were lucky enough to have a service where we had psychiatrists, we had psychologists, that people, we worked with people that addiction service and mental health services turned down, that was actively suicidal, and after intensive therapy and input from the services has become abstinent and is now working as a mental health support worker, which is a brilliant service. But if it had been left to mental health services, that person would have been left, and I don't know what would have happened to that individual. And I think it shouldn't be a barrier to accessing services. The also thing about it is training as well. With us losing NHS services, all our doctors, our psychiatrists, where are they, the next generation, where are they going to get this training from in specialist services if the provision of services is being cut? There's just no experience. And I see it every day. I go to different areas of the hospital, and I'm dealing with extremely intelligent specialist consultants, but I'm really surprised at their lack of knowledge and understanding on alcohol issues and how that affects their patients, because it's clearly not something that's being taught, or being spoken about.
Derek, any comments? You know, I think what you're all saying is, in a nutshell, is this is a problem that pervades every single aspect of society and has a major impact on just about every community service, and has a really major impact across the whole of the health system, from occupational health. Blandina are one of our people who's listening in and asking great questions, from occupational health right through to psychosis, right through to addiction services. And yet we can't, 44 years I've worked in the health system. This is actually the one issue that, if I'm honest, I've never seen much in the way of progress on, either political will-wise or in terms of the understanding about what's needed. And I have a personal view, which is that I think if you have mental health services where more than 20% of your patients have a need, whether it's for physical health checks or educational training or an alcohol problem, and you really think that if at 20%, and most of us it's 50 to 80%, if you really think it's not appropriate to assess that person with that really, really important comorbidity, I just wonder what does that say about our healthcare, medical schools, nursing schools, training schools, if we really can't grasp that something is a core part of a person's problem. I don't know what the rest of you think about that.
I think, is there a wider problem about how we conceptualize alcohol? So back to my comment at the start, and it's acceptable, everyone likes to drink, no one likes a drunk. Well, not everyone likes a drink. And I think, again, were alcohol invented today, it would be banned immediately as a scourge of Britain, and the worst thing since COVID-19. And I think we accept it in a way that we have different conversations to conversations about any other drug that people use. Yeah. I sometimes imagine, and I drink alcohol on occasion, and I've had things, for example, there might be a picture of me online with holding a glass of wine in my hand. What would people think if I had a spliff of cannabis in my hand? I would be fired on the spot. And yet, if you harms from these drugs, I'm not advocating it, I have to say, but I think there's something about how we view, I think it's still seen too often as somewhat harmless. Sure, go on. And this idea about, so I don't think we take it seriously enough as a society. So maybe, again, Becki and Michael have different experiences from being directly in the front line. I don't know Ed from his lived experience of it. But I think within society more generally, there may be shifts, and I don't know what people have thought, and I've seen certainly online more discussions at Christmas. Don't push people about asking people a second time, why will you have a drink, or why not? I'll go on. I think we have a social problem in how we deal with this drug.
Right.
I think, just to come in there, Geraldine, agreeing with Derek and what he's saying, I think the public knowledge about alcohol actually and the effect it has on us is really poor, And, people drink for the same reason they take every drug, because in the short term, they're fun, and you feel great, And what people don't really understand is, in the longer term, it is going to hammer your mood. And, when I'm teaching young doctors or whatever, and we look at some of the theories of how various psychiatric illnesses of the brain, we don't know that much, but we know quite a lot about how alcohol affects the brain. And we know that if you drink it, the brain will adapt to the amount of alcohol you consume, and some of that will be mood effects, and it'll lose its meaning. And so when people come down and they say, I'm depressed, and often the first thing, rather than starting them on an antidepressant or even sending the IOT, is, are you drinking? What role does alcohol play in your thing? And I think that attitude, kind of how we change that public attitude is really important. To me, I think Derek makes that, and change the public perception of it, I think, is really important. Just to say, there are a few little bits of good news on the horizon, I think, Geraldine. So, because I know in a few minutes, I think, like I say, there are a few things. And firstly, your old colleagues, I think from your time as clinical director for mental health for NHSE, Bobby Prapchap and Viral Kantara. And Viral now has made sure that comorbidity with addictions is in the community transformation plans, and everyone needs to take it really seriously. And they have a lot of money to invest. And they're very clear in NHS England that this needs to be addressed in mental health teams, and not like this idea of expecting some special team to come and take it away. So that's really positive. And also NHS Digital have put a screening tool called the Assist Lite for alcohol and drugs, has gone into the mental health minimum data set, and there'll be an expectation. So there are two things I think you can push with the trust, Geraldine, if you bringing things back
Excellent.
about what is the Community Transformation Fund doing with the priority around comorbidity with alcohol, and what are they doing about the Assist Light? And then to say that there's also the last thing that's happening, and those about drugs, it will have a blow into alcohol, I think, is the Dame Carol Black review. And I think you met with her, Derek. I think maybe is that into drugs and the loss of funding for drug services. And that is automatically going to pull more investment, I think, if it gets approved, into alcohol service as well. So it's not to say there's not a huge amount of work to be done, and I think there's a huge culture change that needs to happen both in the public and within services, not to turn away people who are drunk in mental health crises, but I think that there are some good things happening.
Can I just say one thing? I know we're nearly at the end of the time, but I found this book, which is backwards on your screen, but Scarcity, which is by a Harvard psychologist and economist, I think, really, really helpful, because it talks about the kind of myth of choice, right? And I think in public health there is often an emphasis on lecturing poor people about the poor choices that they make. Don't eat so many chips, don't drink so much, don't smoke so many cigarettes, and don't stab each other, whatever it is. And as Natalie Creary from Black Thrive said, we should spend more time lecturing people with resources about their choices, and their choices not to share those resources, because actually what we know from the science of the way our brains work is that choice is very much dictated by your environment and the social determinants. So if you live in poverty, it's much harder to choose to pay to go to the gym or buy a load of vegetables and all the rest of it. And the same applies to alcohol and the use of alcohol. Although I am a middle class person who had a problem with alcohol, it's also driven by your circumstances. And that comes to the point about the stigma of people who have substance misuse issues, because we too often see them as making foolish or bad or wicked, stupid choices, right? When actually the choices that we make are dictated by our circumstances. And so all of us need to work on the circumstances in which people live, whether that's the trauma, the poverty, or the environment in which they are. And all of those things interconnect.
Great. Listen, I'm sure we could go on talking about this for a whole afternoon, but I think in some ways we've got some answers here, haven't we? Communication, getting the facts out there, changing healthcare curriculum for every single professional group, really just giving government the facts across government, and reorganizing big testing services like Derek has done in Bexley, and you have all been helpful around and getting to happen in Lambeth. And Becki, thank you so much for bravely stepping into this bastion of kind of knowledge about alcohol across the road. So thank you very much, everyone. Thank you very much, everyone, for listening. Have a fantastic, not too drunk Christmas. Take care. Bye-bye.
Bye. Thank you.
Bye.